You know, my city is Rennes. Rennes is the capital of Brittany. It's in the western part of France. It's about 300 miles west of Paris. And it's a medium-sized city of about 400,000 inhabitants. It's very close to the Channel. The closest port is Saint-Malo. And you can see here the port of Saint-Malo. And as you know, it's from Saint-Malo that Jacques Cartier in 1534 embarked to discover Canada. Donc, je voudrais dire aussi un bonjour en français à tous les Canadiens francophones qui m'entendent. C'est un plaisir de savoir que vous êtes en ligne ce soir. So, I propose that we consider successively three main parts. We will see first what is today's definition of hemochromatosis. It has changed a lot, you will see. Then we'll see what is new or important for the diagnosis, and finally, what is new for the treatment. So let's start with the first point, which is what is hemochromatosis? The data that I will present here are the main conclusions of an international workshop that was held last year in Heidelberg during the BioIron meeting. And so it's the conclusion from this working group. Today, we consider that hemochromatosis corresponds to, of course, iron overload of genetic origin, and with hepcidin deficiency. So let's see now this notion of hepcidin deficiency. In order to better understand this notion, I just would like to introduce some quick focus reminders on iron metabolism. If we consider the main actors of iron metabolism, you have the liver, you have the duodenum, the digestive tubes, you have the bone marrow, and the spleen, and also the blood, the plasma. The iron in the plasma comes from two main sources. On the one hand, it comes from the digestive tube, from the alimentary iron, and on the other hand, it comes from the spleen, because iron in the spleen itself comes from the degradations of the all red blood cells which reach the spleen, die within this organ, and release the iron. And this iron will be recycled and will go into the plasma. So a double source of iron. Once iron is inside the plasma, it cannot remain as such because a metal in a liquid cannot circulate. So the iron has to be transported, and it is transported by a protein which is named transferrin. And as you can see here, normally, physiologically, there is an excess of transferrin compared to the amount of iron in the plasma. And this corresponds to the clinical, to the practical notion of transferrin saturation. If we represent transferrin no more as a boat, but as a vase in the plasma, you have this yellow vase, transferrin, and normally iron fills part of this vase, but it's only a partial occupation of this vase. And we know that transferrin saturation corresponds to the ratio of iron to transferrin, and that normally it's less than 45%. If we continue to see the fate of this iron linked to transferrin, we know that the main fate is to go to the bone marrow, where the transferrin will release its iron, and this iron will be used to produce new red blood cells, which go into the circulation. So, to go back now to the notion of hepcidin deficiency, if we consider hemochromatosis, whatever due to the main mutation of the HFA protein, the C2A2I mutation, by far the most frequent cause of hemochromatosis, or due to other rare mutations that I have indicated, some of them here, hemojuvelin or transferrin receptor 2, whatever the name, it's not important. The notion is that these various mutations will cause the same disease, the same type of disease, because this mutation shares the same mechanism. What is this mechanism? Those mutations, HFA or non-HFA, will act at the hepatic level. And at the hepatic level, the effect of this different mutation will be the same, that is, a decreased production by the liver of this protein called hepcidin. Hepcidin is a very important protein. It's the iron regulator of iron metabolism in the body. And so the effect of this mutation is to decrease the production by the liver of hepcidin. Since hepcidin is an hormone, that means that hepcidin, once it is produced by the liver, is released into the circulation. So if you have a decreased production of hepcidin by the liver, this will lead to a decreased concentration of hepcidin in the plasma. You will have hypohepcidinemia. And this hypohepcidinemia will have a double consequence. On the digestive side, the effect of these low hepcidin levels will be to stimulate this protein, which is a very important protein called ferroportin. Ferroportin is the only protein known today to be able to export the iron from the cell into the plasma. So when you have a lack of hepcidin, you have an increased activity of this export protein, which means at the duodenal level that you will have an increased entry of iron into the plasma, hyperabsorption of iron. And at the same time, at the spleen level, you will have the same mechanism because ferroportin is also present and very active in the spleen. So low hepcidin level will create an increased activity of export of this ferroportin protein and therefore an increased release of iron to the plasma. So the consequence of hepcidin deficiency is through an increased activity of ferroportin to create a permanent and important amount of iron inside the plasma. So, of course, if iron increases in the plasma, this means that you will have an increase in transferrin saturation. And when you have an increased transferrin saturation, this corresponds often to the appearance in the plasma of a new form of iron, which is no more linked to transferrin because transferrin starts to be saturated, and which is called non-transferrin bound iron. And this non-transferrin bound iron, NTBI, has a double property. The first property is a kinetic one. Indeed, if we see the kinetics of the iron, which is bound to transferrin, we can say that this iron bound to transferrin circulates rather slowly in the plasma, and that its target is, as we have seen, the bone marrow. But it's quite different if you consider non-transferrin bound iron. Non-transferrin bound iron circulates very quickly in the plasma, and its target is not at all the bone marrow, but especially at the first step, the liver. So it will deliver very quickly this NTBI in the liver. And so we can say that NTBI, which appears when transferrin saturation increases, rushes into the liver and will be the main responsible for the excessive iron deposition within the liver. And I have just illustrated this here. You have a liver biopsy of a patient with hemochromatosis, and you can see these blue iron deposits within the hepatic cells. So the first property of NTBI is to rush into the liver. The second property relates to its toxicity. Indeed, when transferrin saturation is over 75%, appears in the plasma a special form of NTBI, which is called RPI for reactive plasma iron. And this is important because this reactive plasma iron represents the potentially toxic form of circulating iron. In other words, when you have a lot of transferrin saturation, transferrin is highly saturated, part of the NTBI is RPI, and this iron, which is NTBI, rushes into the liver, but here will exert a toxicity because this type of iron, RPI, is characterized by its propensity to produce what we call reactive oxygen species, which are elements we are damaging, especially for the membrane of the cells. And today, it's accepted, it's admitted that the organ damage that we see in hemochromatosis is mainly due to the toxic effect of this special form of iron. And this is true for the liver toxicity, this is true for the pancreas damage, and also for the heart damage. So, to sum up this definition, we can say that iron overload, hemochromatosis corresponds to iron overload of genetic origin. This genetic origin may correspond essentially to HFA mutation, much more rarely to non-HFA mutation. And the common denominator in terms of mechanism is that it is due to hepcidin deficiency, which is responsible for this triad: increased transferrin saturation, the very earliest marker of hemochromatosis, liver iron overload, and no spleen iron overload, because you have seen that due to low hepcidin and high ferroportin, the spleen releases constantly and massively its iron into the circulation. So, in a mirror view, what is not hemochromatosis? You have two categories of diseases. First, iron overload, which is not of genetic origin, that we can call acquired iron overload. And you have two main types of acquired iron overload. One is due to multiple transfusion, such situations that you can see, for instance, in chronic anemia in children with thalassemia. And also the second situation is when you have chronic anemia of another cause and you supplement with intravenous iron, and excessive intravenous iron supplementation and produce acquired iron overload. So this is the first category of chronic iron overload, which do not correspond to hemochromatosis. They are not genetic, they are acquired. The second set of diseases which are not hemochromatosis correspond to iron overload, but who are genetic this time, but who are not related to hepcidin deficiency. And we can call this situation non-hemochromatosis genetic iron overload, and I just here will allude to the disease called ferroportin disease that I will say a few words on it in the diagnostic parts that we will now start. So we have seen the definition of hemochromatosis with the common denominator of hepcidin deficiency. Let's now move to the diagnostic aspect of hemochromatosis. And we will see successively HFA hemochromatosis, the classical hemochromatosis, probably 98% of hemochromatosis. Say a few words on non-HFA hemochromatosis, and very few words on non-hemochromatosis, genetic iron overload. So let's start with the diagnosis of HFA hemochromatosis. The main notion here is that this diagnosis has become a totally non-invasive diagnosis. In other words, you don't need any longer to perform a liver biopsy to make the diagnosis of hemochromatosis. You just rely on the triangle of data, which is the following. You have clinical data, biological data, and imaging data. Let's say a word about each of them. First, what is the clinical expression of the classical HFA hemochromatosis? The first expression is, in fact, nothing. You can see nothing during 30, 40, and sometimes 50 years. And it's a big problem because during these black blocks, if you don't check systematically for iron parameters, you will not suspect that you have an underlying silent disease. Big problem for hemochromatosis. When the clinical expression appears, you have two main types of syndromes or symptoms or signs. Three signs which impair the quality of life but do not compromise, do not jeopardize life expectancy. This is first chronic unexplained fatigue, which can be very important in these patients. The second type of signs are rheumatic signs and rheumatologic signs. And you do know that the hands are particularly affected, especially at this level here, and it's responsible for the symptoms that we have described as the painful handshake. And the second location we should suggest hemochromatosis rheumatism is when you have this location at the ankle. There are very few chronic arthritis which are located at the ankle. And often these arthritis are associated always in the rheumatic aspect with early osteoporosis. So we have seen chronic fatigue, we have seen rheumatic disease, arthritis, osteoporosis. The third sign is, of course, hyperpigmentation as illustrated here. So these three types of syndromes impair the quality of life. But if the disease evolves a lot, becomes more severe, you can have three types of syndrome which may really be life-threatening. The first one is, of course, a liver syndrome, and you do know that iron excess over a long time can damage the liver, can produce some scarring effects that we call fibrosis. And when fibrosis is very important, you have this type of liver, which is no more smooth as here, but really the cirrhosis, which is due to iron, not to alcohol, not to virus or other questions. And the peculiarity of this cirrhosis is, despite the fact that you have a true cirrhosis and a lot of iron within the liver, there is a preserved liver function. Liver function tests are almost normal, apart from a slight chronic increase in transaminases. And hemochromatosis dictation has essentially the risk, which is not a certainty, it's not 100%, it's an increased risk of developing liver cancer. Every cirrhosis is able to develop a cancer, whatever its cause. And it's true for hemochromatosis as for the other causes of cirrhosis. So first, the liver. The second is the pancreas, and you do know that you can develop diabetes, insulin-dependent diabetes. And the third organ, you can be severely affected, but much more rarely than previously thought in HFE hemochromatosis, is the heart with case of arrhythmia and eventually possibility of cardiac failure. These are the main known syndromes of classical hemochromatosis. Let's now move on to the biological side. And we will see briefly, successively, transferrin saturation, ferritin, and the genetic. So a few words on transferrin saturation. We have seen that transferrin saturation is the earliest biochemical abnormality that you see in the course of the disease. Increased transferrin saturation, which is often over 60 and 50% in men and women, and in fact often 80 to 100%. And it's important to check twice the abnormality before continuing the diagnostic approach, because the transferrin saturation may be a rather fluctuating parameter. But the message is the following: normal transferrin saturation excludes hemochromatosis. Let's now say a word about ferritin. And just before, a few words about what is ferritin. We have seen that transferrin is a protein which carries the transport iron in the circulation. Ferritin has a different role. If you consider the liver and that iron which has reached the liver, it cannot remain as such in the cells, and it will be integrated within a protein which is called ferritin. So ferritin is an iron storage protein. And part of this ferritin leaks into the plasma, so that the amount of plasma, of ferritin in the plasma, is correlated with the amount of iron in the liver. If you have high ferritin, it usually means that you have high body iron load, iron excess. And so, to come back to the clinical aspects, it's clear that if you assay the ferritin in hemochromatosis, you will most often find an increase in ferritin, and it's over 300 in men and 200 in females. But it's very important when you have an increased ferritinemia to be aware of the false positive, if you want, situation for which you have an increase in ferritin, but which is not related to iron overload. And it's very frequent. And in fact, the most frequent cause of hyperferritinemia is not iron overload. And throughout the world is what we call the metabolic syndrome. And the metabolic syndrome corresponds to all these patients who have a little bit too much of everything, too much of weight, too much of blood pressure, too much of cholesterol, too much of glycemia, sometimes of uricemia. This is what we call a dysmetabolic hyperferritinemia. Sometimes you can say that it's not a ferritin of iron, but a ferritin of fat, if you will. The second cause which can produce hyperferritinemia without iron overload is inflammation, because ferritin is called an inflammatory protein. And the third cause, which can produce hyperferritinemia independently of iron excess, is alcoholism, because alcohol increases synthesis of ferritin. So the reflex when somebody has hyperferritinemia is to rule out these three causes of hyperferritinemia, and then you can really deduce that your hyperferritinemia does reflect body iron excess. Let's now say a word about the genetic test. Of course, when we suspect hemochromatosis, we check that there is high transferrin saturation, then we are allowed to ask for the C2A2I mutation. And the expected result from the lab is the following. We expect C2A2I, C2A2I, homozygosity for this mutation, one mutation received from the father, the other mutation received from the mother. And please, we should really be careful to the interpretation of other genetic profile. We do know that H63D, as such, heterozygosity has no diagnostic value. It's the same for homozygosity for H63D, no diagnostic value. And it's the same and even worse for this mutation called S65C, no diagnostic value. There is more concern about the interpretation, the meaning of what we call compound heterozygosity, C2A2I, H63D. What is accepted today is the following. This genetic profile is not responsible for true hemochromatosis. It can produce some increase in transferrin saturation, 50, 60, sometimes 70%. But by itself, it is not supposed to create hyperferritinemia. And what we think is that the genetic profile is essentially a booster, has a boosting effect, if you want, for increasing ferritin in those situations that I have indicated previously, for instance, the metabolic syndrome. And so the overall message is that C2A2I, H63D does not expose to the risk of the development of significant iron overload and is not a cause of true hemochromatosis. I know that it's often difficult to receive from the patients, but it's very important to transmit this message. So we have seen clinical data, biological data, the third set of data which enable to make the diagnosis of hemochromatosis in a non-invasive way is, of course, magnetic resonance imaging. It has been a revolution for the diagnosis of a chronic iron overload. And you have here a typical picture of an hemochromatosis patient. You can see on the left-hand side a black liver. It means that this liver is full of iron. And we should not forget to have a look at the spleen. And you see as the spleen is a white spleen because you have no iron excess in the spleen. And you see that MRI is very interesting because not only it permits to visualize the iron overload, to quantify the iron overload, especially in the liver, but by evaluating the balance between iron in the liver and no iron here in the spleen, it provides you information on the cause, on the mechanism of your iron overload. So magnetic resonance imaging is very important. We have finished with HFA hemochromatosis. A few words on non-HFA hemochromatosis. These are rare situations. As I've told you, this is hemochromatosis without homozygosity for C2E2I, and you have several types of mutation. I just indicated two of them here, hemojuvelin and TFR. There are similarities with HFA, of course, and a few differences. The similarities are due to the fact that, as we have seen, these non-HFA hemochromatosis syndromes have in common with HFA the hepcidin deficiency syndrome, which means that you have the trial increased transferrin saturation, liver iron overload, no spleen, no iron in the spleen, and clinically, those syndromes share also very close clinical expression, biological expression, and imaging expression. But there are some differences. And what are these main differences between non-HFA and HFA hemochromatosis? Non-HFA hemochromatosis is a rare disease. I remind you that HFA hemochromatosis is only seen in Caucasians, but non-HFA hemochromatosis can be seen both in Caucasians and in other ethnicities. So it's rare, much rarer than HFA, but it's more diffuse throughout the world. The second difference is that usually it affects younger people, less than 30 years old, and the reflex when you have documented massive or important iron overload, especially by MRI, in a person with age less than 30 years old, you should think of non-HFA hemochromatosis, what we call juvenile hemochromatosis. The HFA hemochromatosis usually is over 30 years old when expressed clinically. Third difference, usually it's a more severe disease, especially in the liver expression, in the heart expression, and of course, you need to resort to expert centers for genetic testing because these are rare mutations. Let's say now a word on non-hemochromatosis genetic iron overload. I remind you that we are here in iron overload, who are genetic, but who are not due to hepcidin deficiency, and especially what we call the ferroportin disease, which is a rare disease, but not so rare because it's a dominant disease in contrast to HFA hemochromatosis and non-HFA who are recessive disease. So when we have a dominant disease, it's more importantly diffuse. So what is shortly this ferroportin disease? And we know that in this disease, the mutation acts at the level essentially of the spleen, and the effects of the mutation of the ferroportin protein is to decrease the property of exporting iron from the cell into the plasma. In other words, when you have mutation of the ferroportin disease, you have a decreased activity of ferroportin and a decreased release of iron in the plasma, which creates a retention of iron in the spleen. And so this will be reflected biochemically in the blood by high ferritin because you have high iron overload, iron in the body, but normal transferrin saturation. And this is important because I told you that transferrin saturation, when it is normal, exclude hemochromatosis, but you see here that normal transferrin saturation does not exclude some rare form of genetic iron overload. And these ferroportin disease patients do have significant iron excess in the body, and you can see here a typical profile of a ferroportin disease patient at MRI, and you can see here a black spleen. You remember that in hemochromatosis you had a white spleen, black spleen because here iron is essentially located in the spleen, and only a gray liver because the iron overload is only moderate at the hepatic level. So you see again the interest of MRI to orientate the cause, the nature of chronic iron overload situation. So we can now move to the third and final part, which is the treatment. What is new and what is important is the treatment. Of course, if I show you this slide, we'll see it's not very new to speak on phlebotomies today. It's not new, but it's so important. Phlebotomies remain and will remain probably forever the mainstay of the treatment. In the case for a very long time, the mainstay of the treatment. I just would like here to focus on the blood markers of efficacy when a patient undergoes phlebotomy treatment. As you know, there are two phases, the induction phase and the maintenance therapy. What about the markers of efficacy when you are in the induction phase? The induction phase is, of course, to resort to weekly venesection in order to decrease progressively and to remove all the established iron excess. And we know that the ferritin, which is, I remind you, the iron storage protein which leaks in the plasma, the ferritin in the plasma is in hemochromatosis very well correlated with the degree of iron stores. So the message is that the good marker to follow the efficacy of the treatment during the induction phase is really ferritin. And the next message is very important. Beware transferrin saturation during the induction phase. As you know, if you represent the evolution of the transferrin saturation during the induction phase, this is that. During most of this phase, despite the fact that you remove effectively iron and that ferritin progressively decreases, transferrin saturation will remain very high, totally saturated sometimes the transferrin. And it's only at the very end of the treatment when ferritin is about 50 microgram per liter that suddenly transferrin saturation will return to normal values. So the message is that we should not check the efficacy of venesection at the induction phase by transferrin saturation during most of it. What about the maintenance therapy? For the maintenance therapy, the goal and the main goal is to obtain and to maintain the ferritin level, let's say around 50 microgram per liter. And often this corresponds to transferrin saturation, which is also in the normal range, let's say less than 50%. And we can say that it's a bit the ideal profile. You follow the rule of the 50 for ferritin, less than 50 for transferrin saturation. But we have observed over time that there is a subset of patients, which is pretty significant in number, which do not follow this rule. And despite the fact that you have ferritin which is around 50, if you check transferrin saturation, you can see that they are always with a very high level of transferrin saturations. And a recent work which has been done in our team in Rennes has shown that this type of profile may correspond to patients who develop more fatigue, more chronic arthropathy. And maybe it's due to the fact, you remember, when you have transferrin saturation over 75, you may have in the plasma this toxic form of iron called reactive plasma iron. So what about the message on this is that normal ferritin remains the main goal of the treatment. When you have 50 of ferritin, you should not be worried because there is no iron overload in the body. But you should not totally forget what is done now, usually, transferrin saturation. And I would personally recommend to check at least twice a year transferrin saturation to be sure that you are not in this specific profile of having high transferrin saturation, very high transferrin saturation, despite a normal ferritin level. So what about the other treatments of hemochromatosis? You have two innovative forms of treatment. One is targeted to act at the level of the consequence, I mean on iron excess. It may replace phlebotomy, and this is the problem of what we call oral chelators, oral chelation. And the main drug in this field is called Beferazirox. The commercial name is Exjade. And the effect of this drug, oral drug, is real because this chelator in blue here is able to act at two levels. First, to go really to pick up in the liver the iron and to evacuate it through the bile, through the biliary tract. And also this chelator is able to pick up the iron, the NTBI in the plasma. But there is a problem because, in fact, this is a very rare indication. In most cases, phlebotomies, as you know, are very well tolerated and you don't need to resort to this type of chelator. And the second problem is that it remains today an off-label drug. That means that it can be prescribed, but under the responsibility of the GP and with the written consent of the patient, because of course, as all drugs, this chelator may have some side effects. So the first way is to replace phlebotomy by oral chelation, but in practice is exceptional. And the other therapeutic way is to act no more at the level of iron excess, but upstream of the iron excess. I mean to fight again the hepcidin deficiency, which is responsible for the iron excess. And you have here two ways, theoretical way, but also practical way to treat the patients. The first, of course, if you have hepcidin deficiency, is to obtain hepcidin supplementation. If you restore normal level of hepcidin, you will restore normal absorption of iron, and so normal iron metabolism, no more iron overload. What can we do today? It's possible to increase this hepcidin, which is low, I remind you, in hemochromatosis, by synthetic hepcidin, which can be done in the lab. And this hepcidin will decrease ferroportin and decrease iron absorption, as we have already seen. And indeed, it's possible to synthesize hepcidin and to inject it subcutaneously to increase hepcidin in the body. This is the first approach, hepcidin supplementation. But there is another innovative approach, which is the following. It's no more to act at the hepcidin level, at the hepcidin production level, but to produce ferroportin inhibition. You are downstream as compared to the hepcidin. In other words, you will not act at the hepcidin level here, but you will act at the ferroportin level. And there is an interesting drug, candidate drug, produced by a lab, which can be taken orally and which is able to decrease ferroportin and so to decrease iron absorption. So what is the situation today for these two approaches? We have three main conclusions. The two approaches, either supplementation of hepcidin or decreasing directly ferroportin. The first notion is the following, that in mouse, it works. If you want, if what we call the proof of the concept, if you have hemochromatosis transgenic mice, you are able, by using these two approaches, to counteract the development of hemochromatosis. The second notion, conclusion today, is that if you consider the effect of these two approaches in normal humans, volunteers, what we call phase 1 in clinical trials, it works also. And so what about hemochromatosis? Here it's much more uncertain. And the only trial which has been done in hemochromatosis patients using subcutaneous hepcidin has concerned about 70 patients. And unfortunately, the study has been stopped during the interim report because of very mixed results. So there will still be a long time before we can really resort to the new approaches, but I do think that they are irreversible approaches because they are logical in terms of their goals. It's really to be effective before iron overload develops or after iron overload has been removed by induction therapy. If you have a way to restore normal hepcidin levels or normal iron absorption, you can conceive that you will not be, it will not be any longer necessary to perform a maintenance therapy during 10, 20, 30, 40 years. So it may be a nice goal, but it will still take time. So I have finished. I just would like to conclude by the 5 H. The first H is like hemochromatosis. The second is like HFA versus non-HFA mutations. The third H is like hepcidin deficiency. And the fourth H is like homogeneity, because we have seen the interest of this new terminology, which clarifies the things in this area, is that due to the fact that you have the common denominator of hepcidin deficiency, you have a common approach in terms both of diagnosis and treatment. And the fifth and final H is H I hope, like hope, because the hope is really to increase awareness of this disease, and you do know that it's too often misdiagnosed or even ignored. And here I would like to pay tribute to the role of patient associations, which is outstanding. Just would like to show you the organization in France. We have a French Federation of Association of Patients of Hemochromatosis. We have created almost 15 years ago the EFAPH, which is the European Federation, and you see here the successive presidents. And in 2013 in London, we have also created the Hemochromatosis International, and you see the successive presidents. Now it's Diane Prince from Australia, who is the current president, and I am happy, of course, that the Canadian Hemochromatosis Society I join us with, especially Ray during the meetings. And I would like to thank especially the President Paul Johnston, and I would not like to end up this presentation without evoking the memory of Mary Warder, and we all know all she provided for, all she made for the hemochromatosis patients, not only in Canada, but throughout the world. So I thank you for your attention, and I would be happy to answer your question. Thank you.
Thank you very much, Pierre. That was fantastic. Perhaps we could start by answering a couple of the questions that were sent in ahead of time.
Yes, you kindly sent me some questions, so I will be pretty quick because there are a lot of questions. I would say first, is joint pains in the hands to be expected? You have seen, yes, they are indeed expected. Bronzed skin, particularly on the arms. Yes, you can see bronzing skin, but with reddish blotches. I don't know reddish blotches in hemochromatosis. There was a question here. Yes, somebody who has hemochromatosis has a knee replacement, a hip replacement, and he asked, is it normal that I continue to have worsening symptoms, rheumatologic symptoms, despite normal iron levels? Unfortunately, it's one of the big problems of hemochromatosis. The arthropathy does not respond very well, and often does not respond at all, and may worsen despite removing iron. There is not a direct link between iron excess and arthropathy, and today this is one of the major goals of the research on hemochromatosis, is to explain, to understand why this is this peculiarity of the arthropathy, which may be very disabling, especially in manual workers. And I just tell you that there has been created what we call the HARRY group, which is devoted to try to understand the pathophysiology of this arthropathy. HARRY group means Hemochromatosis Arthropathy Research Initiative. And there was a question, pulmonary fibrosis, is there a relationship with hemochromatosis? No, no relationship between pulmonary fibrosis and hemochromatosis. There were also questions about transferrin saturation. Are there other conditions that can cause an elevated transferrin saturation besides iron overload? Yes, I told you that normal transferrin saturation excludes hemochromatosis. This is true. But increased transferrin saturation may be due to other forms of iron overload than hemochromatosis. For example, in transfusional iron overload, we have also an increased transferrin saturation, so it's not specific. And you can have also an increase in transferrin saturation, which is not due to iron overload. I remind you that transferrin saturation is the ratio of iron to transferrin. So you have two mechanisms for increase this ratio. Either you have an increase in iron, which is the main mechanism in hemochromatosis, or you have a decrease of transferrin. And one situation, for instance, where you have a decreased transferrin saturation is hepatic failure. If you have a patient with a very severe cirrhosis, ascites, jaundice, and you check transferrin saturation, it will be 100%, which is not due to iron overload, but due to the fact that hepatic failure leads to absence of production by the liver of transferrin. So you have no transferrin, and so you have an increased transferrin saturation. Okay? So it's hepatic failure. Another question on ferritin. Can you rule out hemochromatosis diagnosis if serum ferritin is within the reference range or lower? And can you rule out hemochromatosis? Yes. No, you cannot rule out because you have seen that in the course of hemochromatosis, you have first an increase in transferrin saturation, but not yet an increase in ferritin because transferrin saturation is just the transport, the shuttle for iron, whereas ferritin reflects iron deposition in the organ. So in hemochromatosis, you have a long phase with only an increase in transferrin saturation, but not yet an increase in ferritin. So you may have hemochromatosis with only an increase in transferrin saturation, but not yet an increase in ferritin. It's what we call stage 2 of hemochromatosis. Stage 1 is only transferrin saturation with normal ferritin. Stage 2 is increased transferrin saturation with increased ferritin. Stage 3 is these two markers increase with symptoms which impair the quality of life, and 4 is the whole with symptoms which impair the life expectancy. So the answer is yes, increased ferritin can be normal despite hemochromatosis. Okay. Yes, there was a question also on transferrin saturation. Say, this is a discrepancy in maintenance therapy between normal ferritin and, despite normal ferritin, high transferrin saturation. And the question is, what can we do on the therapeutic side to try to correct this? First, I would like to say that what I showed you is based on theoretical view and also on the clinical data, but need to be confirmed. So it's not still widely established. But my feeling is that the goal is to restore not only ferritin, but also transferrin saturation, but to go back to normal iron parameters. And so it's normal to try to have both to normalize ferritin, but also to try to normalize transferrin saturation. But it's true that it's difficult. And what we can do when you have, for instance, 50 of ferritin and 80% permanently of transferrin saturation is to shorten the interval between two successive venesection, or to increase a little bit the volume of the venesection, but you should be careful not to make the patient anemic, of course. You can also try to decrease the absorption of iron by other ways. For instance, it may be one indication of restricting iron in the diet, which is not the rule otherwise. It may be also the advice to take a lot of tea, and which decrease absorption of iron. And I think it will be one of the indications of hepcidin supplementation, because when we will be able to correct the hepcidin level, we will correct the hyperabsorption, and those patients will benefit from this type of innovative approach. These are some of the questions. Maybe, Paul, you have other questions for you?
Yeah, we did have a couple of questions come in about diet, which I believe you just answered. We also have another question from CJC, who is curious about any clinical issues or concerns with someone who is heterozygous.
The question is about heterozygosity?
No, if they only have one copy of the gene.
Yes, when you are heterozygous for the gene, you have not the disease, because this is a recessive disease. You need to have 2 mutations to develop possibly the disease. And so when you are heterozygous, it's 10% of the population. You are not sick. And the usual picture in the family is that a homozygote patient, C2A2I, C2A2I, if you look at his or her parents, father or mother, they are not sick, they have no the disease, because there are only one gene, one mutation And it's the fact that two mutations have incidentally been joined, that one of the children is homozygous. So heterozygosity by itself does not create hemochromatosis.
Great, thank you. Looks like we got another one here. Could hemochromatosis affect a person's ability to accept bone grafts or tooth implants?
I should say no. I think you have to check maybe the bone density to be sure that there is no major osteoporosis, but I don't think that we should be especially cautious with that. Just check the bone density. Sometimes you have periodotitis in hemochromatosis patients sometimes, but for the implants, there is no contraindication. Just check that the bone are okay, I think.
Thank you. Question from SW, is it normal to have symptoms despite being in stage 1 or stage 2?
I think we joined what we said for the maintenance therapy. Stage 1 is when you have increased transferrin saturation with normal ferritin. Stage 2 is when you have increased transferrin saturation plus increased ferritin. So you may develop symptoms. The question is to know whether really people who have a high transferrin saturation despite normal ferritin may develop symptoms. As I told you, there is a clinical study which concludes that it may be possible, but we need confirmation, as always in scientific approaches, to be sure of that. But theoretically and practically, somebody who has a very high transferrin saturation probably may develop fatigue. And you know, if you take young hemochromatosis patients, and you by chance check transferrin saturation, you can see that they are very high transferrin saturation, and sometimes they are already developing fatigue and so on. So I should say it's possible, but it's not yet proven. It's not certain yet.
CJC asks, in areas of Canada with large prevalence of people of Celtic origin, should physicians be screening patients with serum ferritin saturation annually to help identify patients early?
I should say, yes, we should systematically check for transferrin saturation in ferritin in every young Caucasian adult of Celtic or not Celtic origin, but not yearly, not on an annual basis, because if at 30 years old, 35 years old, 30 years old, let's say, a man has a normal transferrin saturation, it's highly unlikely that he will develop hemochromatosis, you know, because transferrin saturation increases very early. So I think that we should, between 20 and 30, check systematically transferrin saturation ferritin at least once. You know, we check several times cholesterolemia and glycemia, and never transferrin saturation and never ferritin. And if we check ferritin, you should check also transferrin saturation. It's quite important. And maybe for the women, it should be also necessary to recheck after the menopause, because as you know, sometimes hemochromatosis will develop after the menopause because metabolism become a little bit like males at this time, and we see sometimes women who have real hemochromatosis at 65 and 70 years old. So in males, probably once between 20 and 30 would be good, and in women, once between 20 and 30, and let's say at 55, for instance, something like this.
Thank you, Pierre. Tara asked, if ferritin is low, under 20, but TS is high, should they have a phlebotomy?
I should say we have first to check if this elevation of transferrin saturation is permanent, so not after a single check. I mean, there is no emergency in this situation, you know. Once, as long as ferritin is normal, everything is okay, I mean, said. And we should not be, I would not like to you to become obsessed by the transferrin saturation. Just, I wanted to say, we should not totally ignore it because it may have some meaning in certain circumstances, but we should be sure that it's constant, so on several months of check that you have an increase in transferrin saturation, a very high one. If you have 50, 55, 60, there is no worry. I mean, it's over 75, over 80 when it is permanent. And then you can try the method that I had proposed. But again, it should not be an obsession. The problem is that when we want to treat somebody, we want to really restore the normal parameters. And I don't think it's good to have normal ferritin and to have permanently a very high increase of transferrin saturation. But again, it's not 47, 52, 60, 70. It's when you have permanently a very high 80%, 90% of transferrin saturation. Then it may be damaging, but it's not yet sure. Okay.
Great. Roberta asked, did I understand correctly that homozygous for H63D will not get iron overload?
Yes, the answer is yes. We cannot exclude that it can increase slightly transferrin saturation, but you know, we have no proof in the literature that no series of patients that develop hemochromatosis. Some patients have been reported developing hemochromatosis, but it was before the discovery of other genes, and it turned out that most of these patients, H63D with iron overload, had a genetic cause which was not H63D, but non-HFA hemochromatosis, you see? So if you document really massive iron overload in H63D, H63 patients, you should check for non-HFA mutation, because a priori, this is not responsible for the iron overload.
And then SW asks, do all C282Y, C282Y get iron overload, or is it possible they would not?
Good question. In fact, it's admitted today that if you take the population with homozygote for C282Y, in women, probably more than 90% of women will never develop any problems of iron overload. And in males, it's about only 25% who will develop significant clinically expressed iron overload. So there are other factors which, if you want C282Y homozygosity, is necessary, but is not sufficient to develop hemochromatosis. But globally, we can say that 50% of persons who are homozygous for C282Y would benefit from venesection, have biochemical abnormalities of iron parameters, but they do not develop clinically significant iron overload, you know. But about 50% of all these populations may have the indication of some phlebotomies.
Another question from CJC, is there a role for neonatal genetic testing?
Oh no, not at all. Not at all, because you know, this is a genetic disease, as you know, who is very silent and not damaging during probably 20 years. And so if you make a genetic test in a neonate, you will have a lot of neonates who will happen to be homozygote and will never develop hemochromatosis. So as long as we have no markers who can say this homozygote will develop or will not develop hemochromatosis, this may be very annoying in terms of discrimination to label these neonates are potentially hemochromatotic patients. So the answer is not. You know, there are some data who suggest that to be homozygote for C282Y could be an advantage during a certain period of life, during infancy, during adolescence, because you need a lot of iron. And so it's pretty good to have this hyperabsorption of iron during until probably 15 after puberty. You know, and there have been also an interesting work from a French team showing that there were more HFA mutations in athletes who were very highly distinguished during the Olympic Games and World Games. And so it's just to say that in hemochromatosis, there is probably a period where it's maybe a benefit, and after a certain period of time, these athletes, and we have seen several of them at 25, 30 years old, become sick because the iron overload is too important as damage, especially the joint and so on. So everything is not black or white, you know, in terms of the effect of C2A2I.
Well, it's 5:03, so it's been 1 hour. We really appreciate your time, Pierre. I'm just going to take everyone off of mute now if they'd like. Just a reminder that if anybody's interested in getting involved in their community, we are looking to develop chapters all over Canada. Please get in touch with Liz. She'll be able to help you out and direct you to some activities that you can organize. Thank you to all our members out there that make events like this possible. Thank you so much, Pierre, for joining us today all the way from France. We really appreciate it. We do have our next event lined up for July 14th. So please stay tuned for that. We'll have Dr. Paul Adams joining us at 7 p.m. Eastern for that presentation. So thank you, Paul. Thank you, Pierre.